My name is Tolu Olaniyan, and I'm the CEO of Pretola Global Health and Consulting. We have 315 people registered on this training from 50 countries. So this training is going to be an interactive one. Depending on wherever you're at, I know I have colleagues, I have people from the UK here, we have people from Kenya, from Iran, Iraq, Bangladesh, registered from different continents registered. So it'll be a good opportunity for us to actually learn from each other and have a good idea of what's going on in other areas that we may not necessarily have the information about. So be ready to engage. Be ready to use the chat function, use the chat box, the message box to uh, actually type in your questions. You know, when the speakers are teaching, feel free to use the chat box. We've muted everyone for a reason so that we don't have, voiceovers, but feel free to use the chat function, ask your questions, ask your questions using the chat function and we will take it. So we have 3 speakers lined up for today. Each session is going to be for about an hour, and that hour will be 50 minutes of teaching and 10 minutes of questions, Q&A. I know 10 minutes is not enough. I do know that. I acknowledge that. But we still have our panel session where we'll have the speakers come back in to join us to take more questions at the end. So feel free to add your questions into the chat box. If we're not able to take everything, during the 1 hour when the teacher is speaking, that's fine. We'll take it all. Whatever questions are left at each session, we'll take it all at the end during the panel sessions. Our speakers are ready to teach and to engage with us. We just hope we can sort out the technical issues. Trying to sort out the technical issues with Dr. Chengo. Is currently in Kenya at the moment. So hopefully we can get him on as soon as possible. If you can, if you're able to, turn on your cameras because we would love to, put some faces to the names and also engage in the topic as well. Hello, Mike. And if you can as well, please put in the chat box which country you're in. So like Tolu Olaniyan, UK, Danielle, Sagri, whatever country you're in, put it in there because then it'll be great for others to have a great, have an idea of where we are all from. Mm, mm, mm. And I do want to acknowledge the presence of, you know, several people here. When we put out the advert, when we put out the information about the training, and then I saw some of the people that registered, I was like, what? How did this happen? Like, but really, thank you all for joining in. And we do not take it for granted, but we do acknowledge the fact that we have parents here, here today. We have carers here today. We have people with epilepsy here today. And we have clinicians here. And the topic we're taking is a sensitive topic. The different cultural and other issues that you may not necessarily face in your country that others may be facing. And I actually also we also have student nurses, medical students, which is great because by the time you qualify as a nurse or qualify as a medical doctor, you're well equipped to be able to meet the needs of people. When we put this training out, the initial the focus at first was for people from low resource countries, but then we thought when we started seeing people from like the US register, the UK register, we're like, why not? Because at the end of the day, epilepsy is global, the need is global. As doctors and nurses, we're going to be working with people from you know different ethnic and cultural backgrounds. So we really need to understand where they're coming from and how to support them. I am a nurse. I work in the UK. I work with people from different, backgrounds and way of life. I really would want to support them, but for me to be able to do that, I need to understand where they're coming from. So it's really good that we're having this. We have a wide range of audience from different countries here. Get ready to learn, even though it may be slightly skewed towards low resource countries, it's still a great learning opportunity. Think about how you can apply it. And also for parents and people with epilepsy, it is a very sensitive topic. We acknowledge that. Feel free to ask questions. And also, if at the end of the training you want to interact, you have more questions, feel free to send us an email using the email address on info@britola.ghc.net. So loads of questions here. The main aim of this training is not to scare anyone. When talking about sudden unexpected death, I remember in 2019 when I went to Kenya and I had to teach and I mentioned SUDEP. I remember the reaction that I had, I received as a result of the fear, and which are valid. And that's why I want to acknowledge today that the fears are valid. The thoughts behind it are valid. The concerns families, people with epilepsy have, and their carers have, they're valid. We're not here to scare you. We're actually here to educate. We're actually here to empower. You can only address risks that you know about, that you're aware of. And that's the whole point of this training. So don't be scared. Hopefully, by the end of this training, you will be more equipped. You would have a better knowledge and idea of how to support yourself if you're a person with epilepsy, and also a family, a parents, carers, how you'll be able to support your loved one as well. And also clinicians will be able to apply this in our practice in our countries. Okay. Now, I also want to acknowledge our sponsors. And this training was put together and was brought, you all registered for it for free because of the support of our sponsors, Danny Did Foundation and Row Foundation. They're two organizations, charities supporting people with epilepsy and creating a whole lot of awareness. And Did Foundation around SUDEP in the US, and also Row Foundation. They've been one of our support network right from the beginning, and they've supported us to put this training together. So I really do want to acknowledge them and say thank you to them. And now we'll go into a quick video from Danny Did Foundation. So I'll just have the team play this video for us, so we have an idea about Danny Did and why we're talking about SUDEP, why we're talking about sudden unexpected death in the epilepsy, the importance of equipping people with epilepsy, children and adults with epilepsy, their families, carers, and also clinicians and non-clinicians, teachers, advocates, everyone. Why should we learn about epilepsy?
My name is Tommy, and I have a story to share. It is a story of one family's journey. It is a story of love, of hope, and of resilience. A story of how one life moves so many other lives. This is the story of what Danny did. It was 11 years ago. Danny Stanton was 4 years old when he died after having a seizure while he was sleeping. His death was caused by sudden, unexpected death in epilepsy. The Danny Did Foundation began as a promise to Danny to protect those suffering from seizures.
I believe in a next blow.
Today, its impact is felt around the world. The foundation has provided thousands of grants to families in all 50 states and across 13 countries. Its programs are designed to make a direct impact through access to life-changing seizure alerting devices, access to educational resources for caregivers, and by advancing public awareness through every medium, billboards, social media, radio, and just this year, our first TV campaign.
Connect with us at DannyDid.org to learn more and to donate.
If people don't understand what epilepsy is, how can they care enough to join the fight? This is the face of epilepsy. And this face. And this face. Since its inception, family has been at the core of the Danny Did Foundation because epilepsy affects the entire family. A new chapter of hope is written every day. I know this story well because Danny is my brother. Although we miss Danny every day, we carry on. With his twinkle in our eyes, his presence in our hearts, and his spirit at our side. Never forget to enjoy your life, just like Danny did.
Thank you. Never forget to enjoy your life, just like Danny did. So that's if we can create awareness, if at the end of this training, every one of us can go out there and create more awareness of epilepsy and have a conversations about people as clinicians, advocates and all that, about SUDEP, about why it's important epilepsy, we manage the risk related to epilepsy and reduce the risk of sudden unexpected death, then our job is done. Our job is done. If at the end of this training we can make changes to our practices, we can apply this ourselves as people with epilepsy and family members and also as clinicians, then we're done. Our job is done. So we're going to go quickly to our fourth speaker, and that is Dr. Eddie Chengo. Dr. Chengo is an experienced epilepsy specialist who has worked for years in epilepsy care and research. He has extensive hands-on medical experience and expertise in research and diagnostics, and has taken a keen interest in epilepsy care and enabling people with epilepsy in their country to receive prompt medical attention and lead normal lives in Kenya. His professional background is in clinical medicine, and he has further studied to become an he has a master's in epilepsy. He currently works with the Foundation for People with Epilepsy in Kenya, which is an IB chapter, and he leads epilepsy projects of organizations and the clinical department as well. He has done a whole lot of work and continues to, inspire people. I connected with him online and I was inspired by just, reading and watching some of the things is done and continues to do. His passion lies in the care of patients with epilepsy in resource-limited countries, advocating for their right to receive optimal health care and enabling them to lead fulfilling lives. He is a co-author, has written several papers and studies on epilepsy in sub-Saharan Africa and engages in epilepsy research, focusing on combating stigma associated with epilepsy. And he's also actively involved in establishing and supporting epilepsy clinics in different countries as well. And yeah, we have him here today to teach us, to actually create, help us to understand SUDEP in low resource countries.
The video on Danny on basically if people basically are aware about epilepsy, then something definitely is going to be done about that. So I think that's the most important thing, especially in low income and middle low and middle income countries. So my presentation, next slide, please, Tolu. So my presentation today is going to be on SUDEP. I'm just going to give an introduction to sudden unexpected death in epilepsy. And I'm going to talk about the burden of epilepsy and then define SUDEP suggested mechanisms. I'll just briefly talk about that because I understand other presenters are going to talk about management. So probably they're going to dwell more on that as they talk about management. I'm going to talk about the risk factors, prevention, and whether we need to discuss SUDEP and how we are going to discuss it in our setups. And then probably I'm going to address the practical ways to address a SUDEP. Next slide, please. So basically, I'll start sharing with you the burden of epilepsy in low and middle income countries. And about 70 million people basically in the world have epilepsy, being a very chronic or a chronic neurological disorder and characterized by seizures. Some of the seizures are convulsive, some of the seizures are non-convulsive. And 90% of these people live in low and middle income countries, and that's a very huge percentage. And according to the data that has always been collected, archived, researched, it has shown that premature death or mortality happens in epilepsy in about 1.3 to 9.3 times that of the background population in higher income countries. And this means that the mortality in low and middle income countries is even higher. Next slide, please. So if you can hear me, yes, thank you very much. So I just want to paint a picture in these first few slides, just to share with us the burden of epilepsy in Africa. And epilepsy is more common in Africa than elsewhere in the world. We've done large studies in Africa, and it has shown that around 10 out of 1,000 people have epilepsy, and that's a huge burden, and it's even higher compared to the West countries, to the countries in the West. So when you look at the prevalence again of epilepsy, just to paint the picture and look at the mortality, in a nutshell, you can say that in every 100 people with epilepsy, 2 will have epilepsy, either convulsive or non-convulsive seizures. And around, and that's the active epilepsy. So the lifetime epilepsy prevalence is even higher in African countries or in the low and middle income countries. And that then paints us a picture on what we should do in terms of the infrastructure that we need to build to ensure that people with epilepsy avoid the morbidities and the mortalities which are high in this region. Next slide, please. So, yeah, so I've already talked about that slide. I think that slide also just paints a picture on the new data on the prevalence of epilepsy and mortality. And the next slide, please. So what about the treatment of epilepsy in this region? The treatment of epilepsy in this region is a little bit unique because of the knowledge base of epilepsy. We understand that, and many studies have shown that the stigma of epilepsy in low-income countries is higher compared to the West. We have also seen that in studies that the health-seeking behavior in this region is also not up to standard. And this is because of what people perceive to be the cause of epilepsy. And therefore, many people with epilepsy will have uncontrolled seizures for this reason, that they think that epilepsy, as much as it presents physically, but the manifestation is more of from a spiritual realm. And studies have been done in Kilifi and elsewhere when you look into the data of Zambia and so many other countries in Africa and other low-income countries, you'll realize that the epilepsy treatment is so dynamic there. They will go to the doctor, they'll go to a witch doctor, they'll go to a traditional healer, they'll go to a faith, healers, and somebody at home will give them something to drink and all these sorts of things. So a couple of things when it comes to epilepsy care or epilepsy treatment in Africa. And, when this happens, then does it really affect SUDEP? Does it really affect the morbidities or the suffering of people with epilepsy? Does it affect the mortality of people with epilepsy? And the simple answer is yes, because the treatment gap is going to be high. Many people are not going to be well controlled because they don't know, they don't understand that. So as we discuss SUDEP, we should also keep in mind of the cultural background of the population that we are also addressing at this point. Next slide, please. So what is SUDEP? So sudden unexpected death in epilepsy is death that occurs with or without evidence for seizures preceding the death, or in which there's no evidence of other disease, injury, or drowning that caused the death. And mostly that happens at night. Most of the studies that have been done have shown that this death happen at night while asleep. Maybe I take this opportunity just to share with you a case study of a 21-year-old male who had traumatic injury, developed epilepsy. We saw him, the guy was okay. He had a seizure like a month before he came to clinic. And then one day the father just said, have knocked into my son's room. He's not opening. I don't know what is happening. I think he's had a seizure. Kindly come and see what is happening. Because they are from nearby, I went and they had already broken the door and the guy, his body was lifeless. It was a very sad story and we attributed that to sudden unexpected death in epilepsy. All the evidence pointed towards that. So SUDEP is real. Next slide, please. Now, the mechanism of sudden unexpected death in epilepsy, which I'll briefly talk about, has been attributed to unstable cardiac rhythms, apnea, and sometimes cessation of the brain activity. So all these mechanisms could contribute towards epilepsy at the point where a person either had a seizure, either witnessed or unwitnessed, and then the heart, maybe a seizuring heart, if you like, and then things happen. The unfortunate happens, which is death. Next slide, please. So, sorry about this slide. I think there are some words that are missing, but the risk of SUDEP is estimated to be 1 to 501 in 1,000 patients per year in community-based population, and with epilepsy, and up to 1 in 100 in surgical series. However, this risk varies considerably depending on the several factors which seem to be important, depending on the risk factors which I'll talk about in the next few slides. Next slide, please. So I just want us to talk about generally mortality of epilepsy. As much as we're talking about sudden unexpected death in epilepsy, but I think the measures, when we look at the management of sudden unexpected death in epilepsy, some of the measures will basically improve the health outcomes or will prevent the premature mortality. So I just want us to paint a picture on mortality of epilepsy in low and income countries. I've just picked these two studies that were done in Kenya. The recent one published in 2021, and it showed that the mortality rate was around 11.2 per 1,000 per year. Both for those who have convulsive and non-convulsive epilepsy, that was too high. And then other studies also done previously have shown that mortality, people with epilepsy are 6 times more likely to die compared to the general population. But what does this really mean? When you look at the study and you go through it, you'll realize most of the causes of this mortality are preventable by simple and inexpensive measures. For example, this study showed that preventing status epilepticus will reduce mortality significantly. Why do people have status epilepticus? Because they don't take their medicine, or because they don't have access to medicine. It's not that they don't want, but they don't have access to medicine. And in this study also, it showed that possible SUDEP accounted for around 7% of all the population that was involved in the study. And that is significant. Next slide, please. And in the same study also, I've just shown some of the, just a table showing the case fatality proportion. And these are studies, some of them were done in Kenya and other African countries, Ethiopia, Cameroon. And you see that, again, people with epilepsy, the standard mortality ratios is high. And when you look at the risk factors here, about 60% of the death attributable to epilepsy factors, particularly status epilepticus, which could again be controlled. Other risk factors are non-adherence to medication, cognitive impairment, focal or frequent prolonged seizures, and generalized seizures for SUDEP. That accounts for 70%. Next slide, please. I hope I'm not very fast. So I'll talk about the risk factors for SUDEP, and I picked this study, which was published in 2019. A very good graph there showing the risk factors and how they're interrelated with sudden unexpected death. So generalized tonic-clonic seizures, chronic and controlled epilepsy, when epilepsy starts at an early age and not treated, the neurocardiorespiratory dysfunction, all these sometimes can contribute to SUDEP. So controlling seizures again becomes a key issue when it comes to reducing the risk of SUDEP. Other factors, some other studies have shown that gender, probably male gender, are more at risk, but different studies talk about different things, about different figures. Some didn't show any difference at all. So I think it depends on the population that was studied. When we look at race, they show some of the studies showed that the African race was more prone to SUDEP compared to the other race. But again, when you look at this, probably there was some bias, or probably the access to care probably for that particular population was somehow not okay. So alcohol, again, this has also been attributed in some studies, and then epilepsy syndromes, especially some studies have shown that symptomatic generalized epilepsy could have a higher risk of SUDEP compared to other types of syndromes or seizures. Next slide, please. So in low and middle income countries, when you look at the infrastructure of epilepsy care, then serious issues have to be discussed. And you can see that already you have that risk because you have somebody has a generalized tonic-clonic seizure, and then compounded with limited access to healthcare and medications, then that's like adding a thorn in the flesh. You won't really wish sometimes that this happens. But this is the reality in low and middle income countries, where there is lack of public awareness regarding epilepsy, where there's shortage of trained healthcare professionals to address epilepsy in terms of care, in terms of follow-up, in terms of psychosocial aspects of epilepsy, the stigma issues. We don't have this infrastructure well. So this just compounds again to the high prevalence of SUDEP in low and middle income countries. And these issues are discussed at the moment. And in the next slides, I'll talk about how we are working on addressing these issues. Next slide, please. So generally, to address the prevention of sudden unexpected death in epilepsy, we need to optimize seizure control, especially the tonic-clonic seizures, which many studies have shown, that can happen. We need to address the issues of adherence to medication, appropriate referrals. Don't stay too long with the patient. Refer as soon as you realize that you can't control the patient with the medication that you're providing, meaning that you can refer to the level 6 hospitals and other places where you think that the patient can get help. I understand that in Africa we have limited resources, but it's possible. Lifestyle issues should be addressed, avoiding alcohol, avoiding drugs, other triggers like sleep deprivation and irregular sleep patterns, which sometimes trigger convulsive seizures or other types of seizures. Sleep supervision by companions or monitoring devices may also be considered, which I think Danny Foundation is doing something on that, as we saw in the video. So in low, next slide, please. So in low middle income countries, there's a typo error there. We have to make sure that we make anti-seizure medication available in health facilities. We need to improve health workers' knowledge on seizure management, have a training that is so deliberate to our CMEs just to improve the knowledge of healthcare workers in management of epilepsy, addressing psychosocial issues, improve primary healthcare in terms of ensuring that the anti-seizure medication are there, the staff are well capacity built, and more importantly, policy change in epilepsy. We are going to discuss a little bit on the intersectoral global action plan in epilepsy, which our country and many other countries are partners in this, and we signed, I think it was last year in May, when member states agreed to make epilepsy a health priority. Next slide, please. So, should we discuss SUDEP with patients? The simple answer is yes. However, looking at the background of what we have discussed in the first few slides, the burden of epilepsy in low and middle income countries, in an already stigmatized population, in a population where you don't have access to medication, in a population where you suffer a lot of discrimination, is it appropriate to discuss SUDEP at that point in time? Yes, it is appropriate, but how are we going to discuss that? Studies done in the West, and this study here published, showed that 52% thought that epilepsy was not associated with higher risk of death. What does that mean? So when you tell them that, okay, now you know that convulsive seizures are associated with higher risk of death, then what? What are you going to do in Africa, in a low-income country where you don't have drug medication, where you don't have what else? These are some of the practical challenges that probably at the end of the slide we'll be able to discuss, but I've already given hints on how we address these issues. So 59% requested detailed information on SUDEP. That's very important. This clearly shows that patients want to understand their diagnosis. They want to know the prognosis. They want to understand how they're going to take care of themselves. And that's very significant. I would love the same if it happens to me or anybody in my family. I want to know so that I can prevent, so that I can make sure that I'm cautious and taking care of myself well. Next slide, please. So I'm going to just talk about the practical ways on addressing SUDEP in low and middle income countries, just to wind up. So next slide, please. So number one is policy change. So that's the thing. We have policies, yes. Some of them are very good. Some of them are not geared towards epilepsy. They are more into either mental health or they're non-communicable diseases. So they don't address the issues of epilepsy. And therefore, the national government should come with policy documents of making epilepsy a health priority. When that is done, then we are sure that we're going to improve the health infrastructure for epilepsy and educate people to address this life-threatening condition effectively. And that is where the IGAP comes in. Lately, we've been implementing IGAP in many countries through IBE or through other initiatives or organizations. And it's about making epilepsy a health priority to improve epilepsy care and reduce stigma associated with epilepsy. Because by doing that, then you are sure that you're going to reduce the burden of people with epilepsy in terms of seizure control and in terms of morbidities and also mortalities. Next slide, please. So number two is capacity building. And this is very important for low and middle income countries where we have fewer specialists for epilepsy. And once we build capacity, we have a pool of knowledgeable epilepsy specialists. Their role will be they'll be resource persons for consultancy, both clinical and policy formulation levels and policy formulation levels, to advise the Ministry of Health or other policy institutions on the prevailing epilepsy needs, whether SUDEP, whether availability of anti-epileptic drugs, and all this that is going to reduce the mortality and improve the health outcomes of people with epilepsy. And also coming up with national epilepsy committees. This is very practical. And these committees will coordinate such activities and then archiving the epilepsy data that is going to inform serious issues like SUDEP. But we need a coordinated activity. And therefore, national epilepsy committees or coordinating committees are going to be effective in doing this type of activity, and therefore hoping that is going to reduce the prevalence of SUDEP. Next slide, please. So when all this is done, then enabling health systems is going to be easy, and therefore stocking of anti-seizure medication that are affordable and appropriate. We should avoid the word cheap just because, the issue of poverty. Because if you avail, for example, one type of drug that is cheap to all the population, just a few are going to respond to that drug. What happens to the rest? So stocking of affordable, but more importantly, appropriate anti-seizure medication is key. Equipping diagnostic equipment, of course, for medical diagnosis, if you like, or ensuring that people with epilepsy understand their diagnosis and they know the prognosis. They know what they are going to avoid so that they don't get the seizures. How are we going to do this without help of diagnostic equipment? Sometimes we need EEGs. Sometimes you need to do MRI. Sometimes you need to do all these investigations because epilepsy is that big diagnosis. But what about the types of epilepsy? What about the syndromes of epilepsy that are going to help us address other issues like which drug is more effective? And what is the prognosis? What are the risk factors that you're going to avoid, or rather the triggers that you're going to avoid? So diagnostic equipment again becomes key, disseminating and implementing existing epilepsy guidelines, and finally, training health professionals. Having a trainer, having you train trainers so that the health system will never lack somebody who is going to pass the information to the other people. Next slide, please. So number 4 is data collection and archiving. That's another practical way of looking at it. When you train epilepsy specialists, the training is going to enhance, diagnosis and therefore facilitate the accuracy of the data archiving. And that's very, very important because we need effective and appropriate medicine for the patients that have scientific or rather evidence-based medicine, and that is going to help even developing policies and therefore sourcing for drugs that work. We understand that the World Health Organization, for example, like a drug like levetiracetam, which is an essential drug, but is it going to be available in the low middle income countries as an essential drug? This is going to be possible if you're going to have information, do research, work on the data that we have, and therefore come up with policies or evidence-based policies that are going to effect the change that we want in reducing SUDEP, and more importantly, discussing SUDEP in low and middle income countries. The conversation has to change, but it has to change to represent the population that we are addressing. Next slide, please. So finally, what about at the facility level, where people see patients with epilepsy, the psychiatric clinics, the epilepsy clinics in low and middle income countries? Let's paint the walls with charts, with epilepsy information, people to understand what epilepsy is, what are the triggers of epilepsy, just something that is going to provoke a conversation about epilepsy with the patients that come to our facilities, and then make epilepsy information available for patients and their caregivers in a language that they're going to understand, and probably a native language. So translate this information. Language speaks to the heart. If you speak with somebody in your own language, they feel that you're speaking from the heart. So translating this information material in a native language is key. And then multidisciplinary approach. Let everybody understand that they have a role in the care of epilepsy at the hospital, at the clinic levels. The psychologists, they have to address issues. They have the psychiatrists sometimes, they come in handy to address the coexisting morbidities in epilepsy. And that, of course, is going to address all the morbidities and also the mortality of epilepsy. Next slide, please. And you see, this is one of the a chart that we have put in our clinic, and it has created a lot of conversation. I do discuss SUDEP, but in a very not quite often. I must confess that, because of the population that I'm dealing with, I have to address other issues before I talk about SUDEP. They already fear that they're going to have accidents that are going to, if it happens in the road, if I'm going to do this and that, and they're trying their best to control their seizures. So number one is to control the seizures. But when they see such a chart, like the reason why we should treat convulsions, then the answers will be there on the other charts. For example, like make sure that you don't miss your medicine. Don't skip, don't miss your medicine, because we are doing this to avoid these accidents. We are doing this to avoid these injuries. We are doing this to avoid these fatalities that can happen if you don't take your medicine. Avoid triggers and all this kind of thing. So this is one of the things that we hope is going to reduce, and it is also going to create a platform on discussing SUDEP. Next slide, please, as I wind up. So we have translated booklets in Swahili. I come from Kenya, and one of the language that we speak is Swahili. And we published this book this year, and it's so effective. I can tell you for sure, because many patients have brought feedback, like, now this book is talking to us. We have also considered cultural background of the population that we are dealing with. So we are addressing so many things that pertain to improve adherence and reduce the stigma of epilepsy, and more importantly, family participation, where every family member will feel that I have a role to play in helping my brother towards epilepsy. And that is, for us, that is one thing that we need to improve on. Next slide, please. So as I conclude, the incidence of SUDEP is in low middle income countries requires urgent infrastructural improvement, so that we can, especially for example, for on the side of the healthcare, we need to increase accessibility to anti-seizure medication. We need to comprehensively educate, to have educational initiatives to educate the public and people about epilepsy, and more importantly, collaborative effort from policymakers, healthcare providers, the global health organizations. All of us will come together to address SUDEP in this region, because it's a burden for us, and we need to address it in a way that is going to make people with epilepsy have better health outcomes. Thank you very much for listening. Back to you, Tolu.
Thank you, Eddie. Thank you, Dr. Chengo. And really a quick wheel top about SUDEP in lower middle income countries. Thank you very much. We've got a few minutes to take some questions, because Professor Roy Shankar is here, and we'll get him all set up ready for our next session. But if you have any questions, put it in there. Remember, like I said, we may not be able to take it now, but we still have our panel session at the end. And for those on YouTube, I know a few people could not get into Zoom. Not sure what was going on with Zoom this morning, but please, if you're on YouTube as well, add your questions into the chat box, and we will take it all during the panel session. Thank you, Dr. Chengo. We really do appreciate that. But you made mention of something, and I think I'm going to start the questions from there. I think we just take about 2 or 3 questions before we take 5 minutes break, and for Professor Rates to join us. And the question I have is, you said, as a clinician, you're a clinician, well-known, renowned clinician in Kenya. You said you don't always talk about SUDEP all the time, but you focus around the risk, addressing the seizures frequency, and putting, getting the seizure under control. Why? Why is there? Because there was something about fear, and I think we need to talk about it. We need to talk about the situation around people with epilepsy and their families. Why there's that immense fear, and I'm in the UK. I'm used to actually telling my patients and their families about SUDEP. I'm used to it, because it's something as a nurse you have to do here. And I know there's some situations you have to hold up a bit and think about it, phrase it, and all of that. But it shocked me in 2019. I was in shock in 2019 when I went to Kenya and I went to teach, and a lot of positive feedback about the content. But there was a parent that came to me and she said, Tolu, you do know that parents don't like to think about the death of their children, right? And that bit of the presentation that I mentioned SUDEP, because the topic wasn't really about SUDEP, it was about epilepsy and intellectual disabilities and autism. And of course, SUDEP is part of it. And that the resistance I felt from that parent was quite immense, and I could see the fear. And I want us to kind of talk about it because you work there, Dr. Chengo. You understand this. Please elaborate a little bit more about this.
Thank you very much. That's a very good question. So number one, I think based on the cultural context of where I come from, death is like a taboo. We don't talk about it quite frequent, and most of the time it's sort of like associated with either somebody's doing something or or have done something. So it comes like a punishment or something like that. So I'm cognizant of that fact because of this is the population that I serve. But more importantly, I'm looking at the infrastructure that when it comes to epilepsy care. My priority will be eliminate the causes or the risk factors for SUDEP, even without talking. Now, if the patient, let me share with you at what point I talk about SUDEP. The point when I start talking about SUDEP is when a patient is not getting it right in terms of adherence. So I'm struggling to control seizures, but the patient is not adherent, not because the drugs are not available. The patient is just doesn't understand. We can see from one of the data, people, almost 52%, more than half, thought that epilepsy doesn't have a risk of death, and that's a significant number of people. So sometimes they just don't feel that is a problem because the seizure doesn't hurt anyway. And more importantly, I need to do something. For example, practically, if, for example, a married man of say 35 years, they have epilepsy, they're on meds and they have, for example, like sexual dysfunction. If they take their pill, then it makes them a little bit woozy. They won't be able to do some other things, and therefore they choose when to take their medication, and then they get these seizures. So for them, they say, okay, I've accomplished my things, but then I'll get like 2 seizures in a month. That's okay. It's just a seizure anyway. So they don't know the risk. So sometimes you talk about the dangers of not taking that medication when you realize that, this patient really needs to understand that this is very risky. They have to take their medicine. They have to control their tonic-clonic seizures. If this drug doesn't work, then they should tell me that this drug doesn't work so that I can change to a better medication, because that's also important for me. I have to give you medicine that works. If it doesn't work for you, it's okay. We'll get another one. So in summary, Tolu, what I'm saying is I choose when to really address this because of, as you rightly put it, the fear. Sometimes it's about the parent also fearing. They're already doing so much. They don't have the knowledge. Even when you look at the study that I presented in this presentation, this study was done in the West. It was not in Africa. There are very, very few studies, I think, that were done on SUDEP and what people think about that. So we need to collect data. We need to have a lot of information so that we can have better ways of addressing SUDEP. But my experience is I'm taking it slow on people. I want to, yes.
Yes.
Yeah, thank you.
So we take it slow. We're sensitive to their need. We're sensitive to environment. We're sensitive to their culture. We're sensitive to their fears. But it doesn't mean that we don't have that conversation at all, or it doesn't mean that we don't address the risk at all. It just means that we have to work with them at their pace. Thank you. I'll take one more question before we go, and there are loads of questions, Dr. Chengo. So please make sure you're here for the panel session to take more at the end. And one last question from Jetta, and the question is, why is SUDEP higher in Africa? In Africa than in other continents? I think the question may not necessarily be about Africa compared to other continents, but I'll probably want to rephrase that as, why is SUDEP higher in low resource countries compared to other areas?
Well, that's a good question. I think I also mentioned that because of the because of the risk. You see, people in Africa or in low middle income countries per se, there's poor control of epilepsy because of the health systems, poor health systems, lack of knowledgeable clinicians to treat epilepsy well. And all these are factors that will contribute to poor control, which as a result contributes to high risk of mortality. Not just SUDEP, even other forms of mortality, for example, status epilepticus. So generally, mortality of epilepsy in Africa is higher compared to the West, where the health infrastructure for epilepsy care is well developed compared to the low and middle income countries. Yes.
Thank you. And we'll pause there for now because there are quite a lot of questions on YouTube, also on Zoom here as well, and we will take them. We'll collate. So for those on YouTube, your questions will be answered at the end. We have our panel session coming on, so we'll take them. And then for those that your questions have not been answered, they're important questions I can spot in there. But I want us to have a little bit of a 5 minutes break and get Professor Ray Shankar here. And thank you so much, Dr. Chengo. We really do appreciate you